where we're going. And in this category, a lot of it has to do with support for the federal bleeding disorders programs. They all say hemophilia in the line, but they their activities apply much more broadly than just hemophilia to all inherited bleeding disorders. And supporting federal policies aligned with our priorities. Those of you who have come, Bill, if you want to go to the next slide, who've come to NHF's Washington Days know that we always focus on the appropriations process, the process that sets federal funding for these programs. So I'm pleased to provide a quick update on that. On the left side, you can see what funding levels for the programs that we care about have been included in House and Senate bills so far. The right side in the kind of purpley color has a more process update. So the fiscal year starts on October 1st. So we are now in fiscal year 2022 that started about a month ago. Congress was not able to pass funding bills before the start of the fiscal year. So they passed what's called a continuing resolution, or a CR, that continues funding at current levels. And this goes for about another month till early December. The House considered and passed out its version of the spending bills. The Senate has not considered the bills either on the Senate floor in committee, but has made their report public to kind of start negotiations. As all of you remember, House passes, the Senate passes. If the language is not identical, they go to a conference committee to negotiate differences, and then they're passed by the House and Senate again. So we're now at the part where there's that kind of conference committee negotiation between the House and Senate about what the final bill is likely to look like. Excuse me, next slide. We do every year not only advocate for particular funding levels, but we also seek inclusion of what is called report language, which is basically a 100-page document that accompanies the bill, where Congress tells federal agencies what to do. So it's organized by agency, so all of CDC stuff is together versus NIH, and it's a way for Congress to indicate to the federal government what its priorities are. We always use that process so that what Congress is telling agencies it cares about aligns with what we are telling Congress it should care about, if that makes sense. So advocacy is from groups like ours is always really key to this process. And you can see here, there's language supporting NIH and the state research coming out of the State of the Science workshop that happened a few years ago. We worked with federal partners on that. The next one is support for the Regional Hemophilia Network program out of HRSA, the funding that supports care that is not, that you can't charge to insurance, so like social worker care, case management, things like that. Next slide. And then there is language for the CDC. Really emphasize this year the need to expand participation in the community count surveillance program to be more inclusive of all aspects of the community. So again, the kind of behind the scenes is that we as NHF's advocacy team met with members of Congress and their staff to say, here's what we think is most important for these agencies this year. We hope that you will work with us to place report language, and we were successful in all of that. What happens next is Congress is negotiating what an end of year package might look like, but this typically agencies have to respond to the report language, whether it's in the House or Senate bill. So as we start the FY23 funding process, which will kick off in the winter, the CDC, for example, will provide information to Congress about how they're trying to respond to this language. So it becomes kind of like an advocacy feedback loop, I'll say. Next slide, please. The next category is blood and product safety and drug approvals. This has long been a key focus of NHF's federal policy work for all of the obvious reasons. We have expanded in recent years to focus not only on safety of blood and plasma products and availability of blood and plasma products, but of course, thinking about drug approval and safety of drugs more broadly, as well as with gene therapy and hemophilia, kind of in clinical trials now and potential approval in the next few years. We want to make sure that the FDA understands our perspective on all of that. Issues that we've worked on this year, well, thinking about during COVID and this year, which of course, unfortunately, COVID is still here. We have really been focused on ensuring that plasma donation can continue and that all the closures around COVID don't preclude that. Customs and Border Patrol, the part of the Homeland Security Department that enforces rules around the border, has also made a policy change about collection of plasma from Mexican nationals in plasma centers along the border that we have been advocating in opposition to, because we want to make sure that there is sufficient plasma and blood being donated to meet demand of all the folks who rely on plasma-derived therapies. We don't have a ton of time to go into detail about everything on these slides, but feel free to ask any questions on this or anything else when we get to Q&A, or you can always follow up with me after. Next slide, please. The third category is support for the comprehensive care model. As Bill said, it's the kind of gold standard. What care do we want every person with an inherited bleeding disorder to receive? Here, I would say what's kind of new are bills in Congress related to the 340B program and ability for covered entities, including HTCs, to be able to participate in that program and generate program income to support their the care that they give. On the next slide, there's information about a new bill that has been introduced, the Protect 340B Act, put in by Representatives McKinley and Spanberger. You can see them here on the slide. And the point of the bill is to try and prohibit private insurers and PBMs from having discriminatory pricing and contract policies that basically make it harder for people to have access to a 340B covered entity. Now, there's a lot of really great stuff in this bill that I think generally aligns very well with long-time NHF perspective that patients and families should be able to choose the pharmacy provider they want. You should be able to choose the product you want. There shouldn't be insurance benefit design that gets in the way of that. But we are working with the offices now to see whether we can go even further in the language to more strongly protect access to HTCs. It's something we're in negotiation on right now, and I'll be happy to provide an update on that once it's a little more final. And then presuming that we're able to come to agreement, I think this is a bill that we will ask community members to join us in supporting, writing to your members of Congress, et cetera. So more to come on this. The last bucket is a biggie around access to care. I have two updates here. And why don't we just go straight there? I'm just keeping an eye on time. So many of you have heard on past presentations about Accumulator Adjustor programs that basically accept copay assistance from manufacturers or from third-party programs, but then don't count that assistance towards someone's out-of-pocket costs, their out-of-pocket max or their deductible. This has been a huge focus of NHF on the federal level, on the state level. You will hear from Bill in just a few moments, as well as in all of NHF's work with payers. Those of you who participated in Washington Days 2021, back in March, will remember that one of our main issues was a letter from Congress to the Biden administration asking them to change policies to prevent accumulator adjuster programs. It was signed by more than 50 members of Congress who were really excited about that. That was back in March, and so we have been working from then until this Monday on November 1st, when the Help Insure Lower Patient Copays Act, or the HELP Copays Act, was introduced. And I am just thrilled to be able to share that introduction with you. Hopefully you have seen information about the bill on NHF social media channels. The bill is awesome. And I don't just say that because I was involved in writing it, but it really does close all of these loopholes that have been exploited to make it harder for people to access their drugs. So the bill changes the definition of deductible, out-of-pocket max, and cost sharing to require plans to count all copays, and it closes another loophole with respect to the essential health benefits for large group plans, again, to make it so all copays count for any covered service. So we are super, super psyched about this bill being introduced, and we really need your help. On the next slide, you can see the list of the original sponsors. Like shout out to these 9 folks, especially Congressman McEachin and Congressman Davis. They are really our champions on the letter that we worked on last year, as well as the bill. And these other folks who joined as original sponsors joined because we, members of our community, asked them to. We have the strongest, best, most effective advocates of any community I've ever worked with. And because you all have built such awesome relationships with your members of Congress and their staff, when you tell them this bill is really important, I hope that you'll co-sponsor it, they listen. And so we need your help to add more members of Congress to the bill, to build more support for it. You can see there's a link here to our Phone to Action campaign, which is our online tool that allows you to write your members of Congress and staff to tell them about something we want them to do, in this case, to co-sponsor HR 5801. You can see the little link there. Maybe, Brett, you could toss that in the chat box too. I don't think I can do that while I'm talking, but I think that would be awesome. Sure. And I also know that some emails are going to be coming out from NHF later this afternoon, kind of with the more formal call to action. So this should be appearing in your inbox in the next couple hours, but you don't need to wait for that. If we can figure out how to get it in there, we would love for you to take action on this today. And again, happy to answer more questions. Awesome. Thank you so much, Brett. Next slide, please. The other update is on one of our biggest advocacy priorities from last year, which was, that's better, the Hemophilia SNF Access Act. This was a key priority for 2020. For many years, we've been trying to solve the problem of Medicare beneficiaries who have bleeding disorders who have not been able to access skilled nursing facilities. So we worked to have legislation in the House and Senate introduced in early 2020, and then the policy was enacted in the end of year package at the end of 2020. Now, we were thrilled that this happened and that it happened so quickly, but I want to caution that it often takes, oh, okay, Perry's saying that that link may not work. We'll get the right one and put it in the chat box. I might have messed it up when I was putting it on the slide. Dylan, I see that, I think you're here. If you could toss in the right one, that would be great. Look at that. A plus right there. Thanks, everybody. So the Hemophilia SNF Access Act, we were thrilled that it was enacted so quickly, and I thought it might be interesting to take a minute and talk about kind of what happens next. So the bill passed last December 2020, and it took effect on October 1st, 2021. So again, about a month ago. If you go to the next slide, what happens after a bill becomes a law? You know, we spend so much time focusing on bills becoming law, but so much advocacy is required after that happens. The first is that we have commented on every year, the Center for Medicaid and Medicare Services puts out a regulation that sets the rules for skilled nursing facilities, and the implementation of our bill, of this new law, was part of the annual. We commented on the regulation this year to make sure that the list of products was updated, and we will every year to make sure that the complete universe of hemophilia, VWD, other rare bleeding disorders products are included. We also have been really focused on education. So the first round is kind of education within our community. You know, this policy is changing on October 1st. Here's what this means. If you're a chapter, if you are a patient or a caregiver, a family member, if you're an HTC, here's what you need to know. And on the next slide in just a sec, we'll have some links for you to see all the information we've put together. We also have done education with the Medicare administrative contractors who implement Medicare policy changes. And we've also worked to educate skilled nursing facilities themselves because of the way bleeding disorders treatments used to be covered for SNFs. They really didn't accept very many people with hemophilia or other bleeding disorders at all. Since that's changed, we need to not only educate them about this law change, now you can bill for these treatments, but we kind of need to go back to bleeding disorders 101. What do you do if you have someone with a bleeding disorder at your SNF? What is a hemophilia treatment center? How do you find them? Who are the ones near you? You know, things like that, so that any SNF that does take someone with a bleeding disorder can make sure to keep them as healthy as possible. Next slide, please. So now, you know, it's a month later. This new law has taken effect. This links here have the NHF resources. And if you go to the NHF homepage, there's like, it's like a widget, I think it's called, that has like the kind of revolving stories. One of them is on the implementation, this top one, of the Hemophilia SNF Access Act. So you can see and detailed info from Medicare. I know HCCs and chapters are reaching out to SNFs in their areas to help troubleshoot individual patient issues. And just like we've been saying for a long time, you know, if you are, or if you know a Medicare beneficiary who needs access to a SNF, please contact NHF. We have many more tools in our toolbox to help folks solve this problem than we did before. Because again of this law taking effect, but there's still stuff to figure out about billing forms and who does what, and you know, the nuts and bolts of medicine. So we're happy to help you, your HTC, your SNF, etc., to make sure that folks can get the care they need. Next slide, please. So this is my last slide, and then I'm going to turn it over to Bill. Wanted to just do a quick teaser for Washington Days 2022. We've decided to do something a little bit different for Washington Days next year. We will first in March, that first week of March, hold a virtual event. So we're still hanging with Zoom congressional meetings, where we're really going to be focused on appropriations. So it'll be trying to get increases for our programs, trying to get appropriations report language like I shared earlier, really focused on that because that's the time of year when Congress starts writing bills. And we think if we're focused, make sure we're meeting with all the right people, carrying the right messaging, that we can really advance the mission there. Then in June 2022, we are hoping to hold an in-person Washington Days. You know, things in Washington have been pretty closed down, not only because of COVID, but also because of the attack at the Capitol on January 6th. And so that's where there's a little bit of a TBD. You know, I sincerely hope that we are able to all be together in June 2022, going to the Hill together. But, you know, that is 7 months away, which is a lifetime these days. So we will definitely be in touch with more information on that, but hope that you guys will plan to join us, you know, either virtually, in person if we can, or using tools like Phone to Action, because we know, you know, with all of our voices together, that's how we have the biggest impact. And with that, I am going to pass it over to Bill to provide a state update, and then we'll be glad to take your questions. Thanks.
Thank you, Joanna. The first thing I'd like to point out is how NHF is structured for advocacy at the state level. Most disease groups, certainly the larger groups, are really more top-down oriented. While they have state chapters, they're often not engaged in advocacy there. It's really directed by the Washington office. But for NHF, we operate in partnership with our 53 chapters, and in fact, in many cases, rely on those chapters to lead advocacy efforts at the state level. Certainly our team, Nathan and Dylan and I, do our best to work with the chapters to stay on top of issues nationally. We work, we represent NHF on national coalitions. So we try to have a two-way flow of communication, if you will, between us and the chapters to make sure we're staying on top of issues and advocating effectively for our community. One of the ways we do that is with this state-based advocacy coalition program. So this program was, and this is an overview poster that we developed for WFH a few years ago, as well as NORD's annual patient summit. And this is kind of a summary of the SBAC program, which was started in 2012. It was started, the goal was to provide, NHF would provide grant money to help the 5 large states with multiple chapters form a single political coalition, if you will, that would lead the advocacy efforts in those states. So we're looking at California, Texas, Florida, Ohio, and New York. And those coalitions exist today. A few years later, we expanded the program to chapters, to states that had just a single chapter within them. And we added, I think at that time, 5 more states. And the program has grown since. I'm not able to see it on my screen, but on the right-hand side, you'll see sort of the evolution of the program to where it is today. In 2021, we had, whoops, sorry about that. So we had 15 grantees, 15 chapters that were awarded grants in 2021, 3 in what we call the capacity building phase of the program, which is aimed at chapters that are really new to advocacy or don't have much of an advocacy program. So it's, we provide grants of up to $7,500 that act as seed money to help chapters get an advocacy program started. And then we have another pool of money in what we call our advanced advocacy grant program. And this year there's 12 chapters that are grantees in that program. And that program was developed because we saw a difference in need between some of the chapters that are just getting started with advocacy, or some chapters that really struggle with it, and then chapters that are much more advanced with their advocacy efforts. And so we wanted to split those up so we could essentially really provide a lot of hands-on help to those smaller chapters that are starting to get advocacy, but also provide maybe a little bit more money for chapters that are more advanced and that are very active in advocacy and very successful. And those grants are up to $15,000. So to date, in the, I guess, 9 years the program's been around, 29 states either are in the program or have been represented in the program at some point. Not every state applies for grant money every year or receives it, but we are covering most of the country, which is really terrific, and probably looking at the states that are covered, certainly on a population basis, a majority of the country is covered by our chapters in the SBAC program. Those grantees, particularly the ones that have advanced programs, but many cases other ones, usually are very active partners in state legislative coalitions during their state legislative sessions. And in some cases, certainly in the last few years, we've seen our chapters step up and be leaders in legislative coalitions in some states. As you might imagine, with 50 states and 50 state legislatures and thousands, if not tens of thousands of state legislators, there's a lot of activity at the state level, and the way we handle it differs very much than what goes on at the federal level. Generally, if I was going to categorize our advocacy priorities in buckets, the way we look at it really, I think the big one we face a lot of is making sure our patients have access to prescription drugs. We're a rare disease, very expensive medications, so often restrictions on access to prescription drugs is a problem. And so we deal with that in many different ways at the state level. Also, we want to make sure you have access to insurance, commercial insurance, or else state Medicaid programs or other programs. There are some states that have programs specifically for people with bleeding disorders, like California and Michigan and others. So we want to make sure you can get access to insurance so that you can afford your medication. The other area that we really get involved with is access to appropriate care. In this case, it is for direct health care, getting access to your hemophilia treatment center. So whether that is network adequacy laws or programs, where we want to make sure treatment centers are included, that are covered by insurance plans. It also could mean to make sure you have access to the specialty pharmacy or the hemophilia treatment center of your choice to get your medication. So those are generally the three areas we work in. And these are some of the specific issues we've been involved in the last few years, and we expect to be involved in going forward. The first one is step therapy. The majority of states in this country have now adopted some form of step therapy legislation. Step therapy is an insurance utilization management practice that may require a patient to fail on one or more less expensive drugs before they can get access to perhaps a more expensive drug that their provider has prescribed for them. Obviously, for people with chronic diseases, this is a serious problem because we want to make sure for people with chronic diseases, access to their prescription drugs is vital. And so we work at the national level with a group called the SAME Coalition, SAIM, which stands for State Access to Innovative Medicines, to enact step therapy legislation around the country to ensure that it doesn't prohibit the practice of step therapy, but it basically creates an off-ramp, if you will. So if you meet certain conditions, you don't have to go through step therapy, and we can make sure you access your prescription drugs. As I mentioned now, I think we're up to 28 or 29, maybe even 30 states that have enacted some form of legislation restricting step therapy. This past year, Arizona, California, Nebraska, and Oregon passed bills. And I know in every one of those cases, our chapters or coalitions in those states were very involved in those efforts. Particularly now in Arizona and Oregon, as well as the Hemophilia Council of California, were involved in coalitions of various sorts that were also led, or the umbrella group of this led by the same coalition at the national level. And I know the New England Hemophilia Association, Rich Pizzillo, led a coalition in Rhode Island, and Rich was actually named to a legislative study commission that the legislature set up the year before in 2020 to study the issue of step therapy. So Rich has been very much involved there in step therapy, as well as frankly in other states in New England like Massachusetts, where legislation is still active. Another area is rare disease advisory councils. There are a number of states, 16 states have now have created rare disease advisory councils. This effort is generally led by NORD, the National Organization for Rare Diseases, but our chapters And NORD has model state legislation, you will, and they kind of lead those efforts and recruit other disease groups. And so we have chapters that have been involved in those efforts. Most recently in 2021, West Virginia and South Carolina were active members of their coalitions that led to the creation of rare disease advisory councils in their state. Another area, and this gets into the cost of prescription drugs, as I mentioned, and this is something we've talked about a lot in the last year or so, is copay accumulator adjustment programs. To date, 12 states and Puerto Rico have passed copay accumulator bills, which is great news. Going into this year, so 5 states had already done this prior to this year, and this past year, 7 states and Puerto Rico passed bills. So, and I'm going to talk about that going forward as well. Particularly, I can point out that in states like Michigan, North Carolina, and Wisconsin, the bleeding disorders coalitions or chapters in those states led those efforts. And there were also leaders in other states where legislation unfortunately didn't pass this year. So this is the map of looking. This is just a snapshot of 2021. This is states in yellow, as well as states in yellow were states where legislation was active this year, either introduced or was part of another bill with copay accumulators. The green states are states that have, again, as of this month, have adopted legislation, and again, 7 of those were this year. Obviously, at this point, not all of the states in yellow are still in session. There's only about a handful of states still in session. So we anticipate that certainly in many, if not most of the states that legislation didn't pass this year, we're going to try to reintroduce it next year. There are still a couple of states where things are still active. I think Ohio and Pennsylvania. Michigan is still in session. But I think right now we're probably in most cases focused on 2022 for those efforts. So I wish I could get this bar to disappear up here. Looking forward to 2022, so 46 states will be in session next year. There are 4 states that only meet every other year: Texas, Montana, North Dakota, and Nevada. Oregon, and there may be other states I'm familiar with. Oregon has a short session next year. It's only 30 days, which really limits what we can do, and you really have to be involved early. And legislative leadership really decides what gets on the agenda for the short session. So it doesn't look like we'll probably be pursuing a copay accumulator bill in Oregon next year just because of the short session. Critically, 2022 is an election year. And so that changes the dynamic, certainly at the federal level, but as well as the state level. At the state level, obviously, most of the state legislatures are done by July or certainly by August. And so legislators have an opportunity to campaign. But it certainly does affect the agendas of state legislatures as well as what will pass. So it's always an interesting dynamic in even numbered years about what you're going to be able to accomplish in a politically charged year. On step therapy, I know the same coalition, which has its annual meeting in August, and we start looking at target states for 2022. This is very preliminary right now, but even though California did pass a bill this year, there is an interest. We didn't quite get the bill we wanted, and so there is interest in maybe making some tweaks to this year's bill. Colorado may be a target state for step therapy, as well as Massachusetts, Missouri, and Pennsylvania, while it's still in session. That may roll over to next year as well. But again, all of these are really preliminary right now, and really won't be probably finalized until for another month or maybe even until January. On the Rare Disease Advisory Council effort, as I mentioned, 16 states have already established advisory councils. 14 states had legislation introduced in 2021 that didn't pass. These, again, are likely to be targets in 2022 and perhaps other states that have not considered it. But certainly, we try to work with NORD to stay on top of those. But that's really an effort that they lead, and to the extent we can, we'll try to keep on top of that and make sure our chapters are in touch with those efforts. On copay accumulator adjustment programs, our Wisconsin bill is dead for this year. While the legislature hasn't adjourned, we are already focusing on 2022. I think the situation is largely similar in Michigan because the copay accumulator bill is tied up in a larger bill that includes a number of other healthcare priorities. And right now that's kind of bottled up in the legislature. Rhode Island, we certainly are maybe looking forward to leading an effort there, as well as in Colorado. Our Colorado chapter has their advocacy stakeholder meeting next week. And we're talking about perhaps the chapter leading that effort in that state. And there'll certainly be other efforts. Colette Culiano sits on our national All Copays Count Coalition, and I'm participating in the state All Copays Count Coalition calls. And right now we're sifting through the states where we might have an opportunity. There is an effort already underway in Utah. The coalition has been established. They're already educating legislators, but their focus is really in 2022. And undoubtedly there'll be a number of other states as well. Once we figure out what the landscape is, and key to that effort is having a patient advocacy group lead that. So finding somebody that is willing to take the reins and lead a coalition effort there is obviously vital to the effort, and we don't move forward without somebody volunteering to do that. I could spend a lot of time talking about Medicaid. If you participated in the Insurance and Reimbursement Conference last week, our team gave a presentation on the work that we're doing with state Medicaid agencies on ensuring that hemophilia and other bleeding disorder products are not managed under preferred drug lists. Currently, 22 states manage products on a preferred drug list, which is something we oppose. It can make it, and often does make it, more difficult to access all the drugs that are FDA approved. If states can set up some barriers to those, but they can't prevent access to them. So that effort continues, and Matt Dull, who is our Medicaid consultant for Artia Solutions, also gave a very comprehensive overview of the landscape of hemophilia management with state Medicaid agencies, as well as the trend towards single state drug lists and states basically carving out their pharmacy benefit from managed care. While managed care dominates healthcare management in the Medicaid program around the country, almost 80% of Medicaid patients are in managed care. There is generally a trend right now to see the pharmacy benefit carved out of that, because states are looking for revenue generators, and by carving out the program, they can then solicit manufacturers for supplemental rebates to bolster their Medicaid program. And obviously Medicaid is an issue everywhere because it's probably the largest chunk of most states' budget. So it's an area we focus on very closely because many of our most vulnerable patients are in Medicaid, and Medicaid is often the subject of cost cutting and restrictions, and we want to make sure our patients aren't harmed in that effort. So we could do a whole presentation on what's going on in Medicaid. For example, one of the things we do today, in fact, in about 15 minutes, Nebraska's Pharmacy and Therapeutics Committee is meeting, and they have the hemophilia class on review. They're not proposing any changes, but Nebraska has one of the most restrictive preferred drug lists. 2/3 of Factor VIII products are non-preferred, and only one product for Factor IX is actually preferred. So I submitted testimony to them earlier today, and we hope to try to influence those efforts, not just with testimony, but working with community members to meet with Medicaid agencies and testify at Medicaid agency committees when we have the opportunity. And with that, I think that covers our state update for 2021, as well as our focus on 2022. And Joanna and I are both happy to answer any questions you have.
Great. Thanks, Bill. Thanks, Joanna. We do have some questions that have come in. Bill, if you can stop sharing when you get a second, and I will get into the first question here. First question comes in. Is there a role, this came in during the federal update that Joanna was giving, is there a role for chapters or community members in these areas of focus for advocacy?
Oh,
Really general
absolutely.
Sorry.
Yeah. No, absolutely. You know, these I'm not sure if you mean like the general buckets or the priority action teams, I guess, before I say absolutely, but I'll answer most generally and then see if any of my colleagues want to jump in. But no, I mean, NHF's federal and state advocacy is way more than NHF employees and consultants. You know, we need all of you to join us in advocating, both in Washington using phone to action, Washington days. You know, many of you will send targeted emails to, hey, we really need you to call this legislator's office today on this issue, and you guys are always so wonderful about responding. And I know that's true on the state level too, both identifying opportunities and following through on them. So yes, you guys, you're critical to our success in advocacy.
Thanks, Joanna. Len, if you're there, you might want to chime in on this question. I'll throw this out. It was came in early. It says, how are the NHF's new focus areas chosen?
So it's a great question. These are areas of perceived greatest need in the bleeding disorders community based on input that was provided by the community, our subject matter experts, patients who live with these disorders, healthcare professionals of all varieties, chapter leaders, et cetera. So the 5 priority areas, again, digital health, mental health, future therapies, von Willebrand disease, and rare bleeding disorders. So I think it's pretty clear why von Willebrand disease would be, one of those priority areas given the recent publication of the von Willebrand disease guidelines. And given everything that's happened with the COVID-19 pandemic, mental health is a pretty clear area of focus for us as well. And then, you think about the other areas, future therapies includes cell gene therapy and gene editing, which is currently on the forefront. And then when you think about digital technologies, that's an area that we don't have much activity, but we really need to increase our capabilities for consumer education, for medical education and information, public policy, payer relations, and of course, research. And then the rare and ultra rare disorders, again, an area that has really deserved more focus and more attention in the past. So we're really hoping that these 5 areas can really progress the organization, but more importantly, progress the community forward towards that 2030 blue sky vision.
Great. Thanks, Len. Appreciate that. Next question that comes in, I'll ask Joanna and Bill, actually, if you both don't mind chiming in on this. Great question. What has been the biggest advocacy struggle for NHF's policy team during the pandemic?
I can speak for state efforts. I think for a number of reasons, not being able to assemble in person in a state capitol has been huge. We totally understand why these restrictions are in place. And virtual is a substitute, but not being there in person, I think the energy that our community members get and share when we're all together, I think has been tough to recruit people. Although we have a number of chapters have had advocacy days, virtual advocacy days with great attendance. So there has been advantage, but my sense is that not being there in person is tough to recruit people. I also am not convinced yet that virtual advocacy is as effective as in person. Having testified at some P&T committee meetings, I don't know if anybody's listening to me. I feel like I'm talking into a black hole. It's hard to replace that person-to-person contact, whether it's with a legislator or even community members having a meeting together. That's my thoughts at the state level.
Yeah, and I don't disagree, and I guess just to say something different, I think in Washington, the struggle has been that everybody's been focused on COVID almost at the exclusion of anything else. That's less true this year as Congress is working on a number of these really big packages, but last year, it was hard to get anything done if you couldn't tie it to COVID. Now that created an opportunity for us too, because because of the severity of the pandemic and its impact on basically every aspect of our lives over the last couple of years, Congress has been passing really big bills that are not totally offset, that include any number of policy priorities in them. And so I think that's part of how we were able to have the Hemophilia SNF Access Act enacted so quickly, was because there was a big bill that had lots of policies, including some Medicare stuff, and we could kind of slip in. So it's been kind of a challenge and an opportunity.
Great, thank you. And again, if you would like to ask a question, please use the Q&A feature or the chat feature at the bottom of your screen. I do have one more question that came in, and that is, I think, probably one that we thought we were going to get here, but have the midterms had any impact on what the community is trying to do, and any impact in a negative or positive way that you can see?
Well, Bill, I mean, I think more happened yesterday on the state level. You know, that it was a state level election day in some states and not a federal. I think thinking about the impact of the midterm elections and how soon in 2022 Congress is going to stop working so they can go home to campaign is something that Bill kind of referenced on the state level too. But curious if you see an impact in, say, Virginia, you know, next door to where I live in DC, which will have a new governor, you know, what impact you're seeing there.
Yeah, you know, when I hear about midterms, I think about Congress mostly. And so it didn't occur to me right away. Yeah, since I don't cover New Jersey or Virginia, you know, I tend to think, you know, predictions or prognostications of radical change are a little bit overstated. It's, you know, politicians certainly once they're elected tend to tack towards the middle if they want to get things done. And so I don't see radical change. I would yield to Kelly if she was on, or anybody from New Jersey, as to how it would impact things in sort of the short term. I would hesitate to say how much it's going to change in the state of Virginia in the next few years.
Yeah, and I'll just add one other thought. You know, Congress is right now trying to land another couple of big bills. You know, the bipartisan infrastructure framework, or the BIF, which I just think it's funny that that's like a term of art now, and the Build Back Better reconciliation package, more focused on social infrastructure. You know, and there are policies that would affect the community that are in both bills, you know, if they come together. And I think, as I think about big picture political events or trends and how they affect us, I guess that's what I'm looking at more closely. You know, do they come together? What final bill language? How will we be affected, et cetera? I would guess that those may be the last big things Congress does before the elections next year, but you know, we'll have to see if they can do these first before we move on to the next package.
Great, thank you both. We still have a couple of minutes here. We do have another question that came in, and this is: if you have to name one, which of the current policy projects are you most excited about for the inheritable blood disorders community? It's a tough one.
I know, right? I'm excited about everything, which is kind of a cop-out answer, I'll acknowledge. I guess I'll go first. I've got the mic. I'm really excited about the Accumulator bill, the Health Copays Act that was just introduced this week. I think we have a really, really great opportunity to build support for that bill, get that policy changed on a national level, which will affect, you know, everybody with private insurance. You know, we have a tough row to hoe with the bill, but I'm really excited about it and know that our community, when we all focus on something together, are pretty unstoppable.
Yeah,
what about
Brett,
you,
you mind if I share my screen just really briefly? There's something I want to throw up there.
It's all yours, Bill.
For those people that might not be aware of it, this is our state coverage map as it exists today. The red is my states. Dylan kind of covers the green states, and Nathan has the blue states. Although Nathan is now relocated to Illinois, and Dylan will be leaving us and we'll be rehiring. So there'll probably be some shuffling of this, but just for those people that may not be familiar with how we cover the country, this is what it looks like. Yeah, I agree with Joanna completely. For my money at the state level, going on right now, the accumulator adjuster, I think momentum is really terrific. We've got 12 bills passed in really 2.5 years. I think that momentum is going to carry into next year. The other thing that's maybe a little bit more on the horizon, but I think NHF is going to play a central role in that, is public policy changes around gene therapy. That's really kind of a game changer on a reimbursement level, if you will, or how those drugs will get paid for. That will require probably some modifications of public policy at the federal level and certainly at the state level, whether it's especially in the Medicaid agencies. So that is an area that I think is very exciting going forward. And simply because of the products that are in the pipeline coming out, hemophilia and bleeding disorders, NHF has an opportunity to be right out front with that.
Great, thanks. Thank you both. We do have a question that came into the Q&A, if you don't mind. It comes in from Paul. Paul asks, how will Medicare drug pricing negotiations impact access to factor therapies?
So I was expecting a question along these lines, Paul. It's always great to hear from you. And, it's a little hard to tell. They have reached agreement on some drug pricing provisions to be included in Build Back Better as of yesterday at this time. And they have not released any bill text yet. I've only seen a 2-page summary of what's in the bill, which talks about negotiation of up to 10 drugs, of the prices of up to 10 drugs in Medicare, and kind of which drugs those are, what protections there are, whether we would be affected. It's really too soon to tell. I will say generally that we have a relatively small percentage of our population are Medicare beneficiaries, which isn't to say I don't worry about the impact on a smaller group of people, but community-wide, just this policy will likely not have a huge impact, but it's too soon to tell if it'll impact us at all. When there have been other policies in the last couple of years to propose to tie drug prices in Medicare to prices paid in other countries, our products were excluded from that. And so it's really hard to say whether we're in or out of the bill language and if we'd be in or out as implemented. So that is not a super helpful response, probably. But I'll just say it's something that we're really keeping a close eye on. And of course, if we think there's any risk of folks not having access, we will definitely get in gear.
Well, Bill and Joanna, we are up against the hour here. I'd like to thank you both for joining us this afternoon. A lot of information there, a lot of good information, and a lot of exciting things coming up here. So we truly appreciate your time. Thanks for being with us. Please note that this recorded webinar will be available on Friday, November 5th at hemophilia.org under the events tab with all of our other archived webinars. Also available in the events tab are our upcoming schedule of our weekly Wednesday webinar series. Joanna and Bill, thanks again for joining us, and everyone have a wonderful afternoon.
Thank you, everyone.